quickly as possible. So the intercanine width increase in maxilla in girls is usually completed by around 10 to 12 years of age. In a flush terminal plane is present the deciduous dentition, then how will you expect the permanent molars to develop? Like in the deciduous dentition, it is a flush terminal plane. So the permanent dentition, how will they erupt? So they will normally erupt in a end-to-end relationship or in a edge-to-edge molar relationship. Later they might go into a class 1 molar, but initially it will be a edge to edge. Now how will they go into a class 1 molar? It is by utilizing the early shift or mesial shift, early mesial shift or late mesial shift, by using your primate spaces or your leeway space of NANCE. Okay. So whenever there is a distal step, as I told earlier, that the lower dentition is far behind, distally placed to the upper dentition. So the distobuccal cusp is sitting. So this will go into a class 2 molar many a times. Okay. And a flush terminal can go to class 2 or an end-on or a class 1. Okay. And the mesial step will either go to a class 1 or a class 3. Mesial step is where the lower dentition is mesially placed or far ahead. Okay. So initially when you see an edge to edge relationship, it is end on relationship. So the flush terminal is more favorable to have a class 1 relationship in the permanent dentition. Okay. A flush terminal plane, as I said earlier, is the distal surface of both the upper and lower second deciduous molars. Okay, in the vertical. So in the permanent dentition, you see either flush terminal or end on or a class 1 molar. If you see a mesial step, you see either a class 1 or a class 3. If you see a distal step, it will be a class 2. So disto-occlusion, distal step, class 3. Mesio-occlusion, prenormal occlusion, mesial step, class 3. Okay. Post-normal occlusion, distal step and disto-occlusion, class 2. So cusp-to-cusp relation in molar is self-corrected to class 1 by only the upper molar drifting backwards, both molars by forward molar drifting of only lower arch, both upper and lower arch, or not self-corrective. That is, flush terminal plane is also an example for transient malocclusion or self-correcting malocclusion, isn't it? It is not a malocclusion. So here what he says is drifting occurs, mesial drifting, only in the upper or only in the lower or both in the upper and lower. It is both in the upper and lower, but more in the lower. Clear? So don't misunderstand. Just write only the lower molars drift, it is not correct. Both upper and lower drift, but lowers will drift more mesially. So flush terminal is corrected, self-corrected to class 1 by both upper and lower drifting, and lowers drifting more. So about 4 mm forward movement of lower molar relative to the upper is what is required for a smooth transition from class 1 in the permanent dentition. And where from this space is gained is either by the differential growth of the lower jaw. There will be some amount of differential growth. The lower jaw will grow slightly more beyond the upper jaw. This is again, go back to your cephalocaudal gradient of growth. Since the lower jaw is away from the cranium, so that will go relatively more when compared to the upper jaw. So that differential growth of the lower jaw will account, and the other one is your physiological or leeway spaces. Okay. 8-year-old child has first molar cusp-to-cusp relationship. What is the treatment? Do you need to do any treatment in that condition? 8-year-old child, either with a fixed, removable, or a recall and observe, or none of the above. It is a self-correcting anomaly, so it can be either observed and checked. So there is no point in doing any treatment, nothing to panic. Okay. Ugly duckling stage is characterized by all of the following features except. Now, ugly duckling stage is nothing but a broadband phenomena where you see approximately at 8.5 to 9.5 years of age, where you see distoangular inclination of your incisors and then this basically disto-angular angulation is an angulation, not the inclination of the incisors, and then an increase in some amount of overjet, and mandibular lateral incisors lingual to central incisors, and deep bite. You can see deep bite, but option C is not what you see in a ugly duckling stage. These lateral incisors are not lingual. The lateral incisors are in line because the lateral incisors are flared. The lateral and centrals are flared disto or distally inclined. Okay. So the choice is the lateral incisors lingual to the central incisors is not seen in ugly duckling phenomena. So it is also called broadband phenomena, which is a self-correcting phenomena. It is a transient malocclusion. No treatment is required. So whenever you see a midland diastema, when a patient comes to you at the age of 8 or 9 years and complains of midland diastema, you should not be in a hurry to do some treatment. So you should explain the patient why this is normal, what is the physiological condition here, since the canines have not erupted. Okay, then once the canines start erupting, the crown of the canine is touching the roots of these teeth. That's why the crowns are flayed distally. So you see why this was not there at the age of 6 or 7? Because the canine crown has not touched the root of the incisors. Okay, so that is the reason you see this peculiar phenomena only between 8.5 to 9.5 years of age, once the upper canine touches the root of the lateral incisor. Okay, so no treatment is required. The moment the canine erupts into the oral cavity, automatically the inclination of the angulation of both the incisors gets corrected and the midland diastema closes. So it is seen between 8 to 10 years of age during the eruption of permanent canines, and the developing canines erupt, the roots will again displace back to the normal position, whereby the inclination is corrected and the midland diastema is closed. So it corrects by itself when the canines erupt and the pressure is transferred from the roots to the coronal area. Okay, and deep bite is also seen during the mixed dentition period, and option C, that is, as I said, the placing of the lateral incisors lingual, that is not seen. Deep bite is present because in mixed dentition you don't see the eruption of your second molars by then. The moment your second molars erupt into the oral cavity, the deep bite is automatically corrected. Okay, till the eruption of second molars, whatever deep bite you see is almost normal. Broadband phenomena occurs during the eruption of the following permanent teeth. Which teeth? It is canines, the permanent canines. Which of the following is a self-correcting anomaly? Obviously it is a ugly duckling stage, where no treatment is required. The moment the canine erupts, it is self-correcting by itself, called as a transient malocclusion. Deep bite, you have to do some or the other treatment, isn't it? As I told earlier, if it is a true deep bite in a growing stage, in a growing patient, then you can give an anterior bite plane, which will allow the passive eruption of the posterior teeth or supra eruption of the posterior teeth, which are in infraversion. So that will correct your deep bite. If it is a pseudo deep bite or a false deep bite because of the supra eruption of your anterior teeth, you have to intrude the anterior teeth. So deep bite cannot be self-corrected, it has to be treated. Then retrusion or protrusion. If the teeth are retroclined, you have to procline them using fixed appliance or your Z spring if there is space. If they are proclined, they have to be brought back either by your fixed orthodontics or by your labial bow, any appliance. Okay, they are not self-correcting. So in what are the self-correcting malocclusions? In various stages of dentition. In pre-dental stage, a retrognathic mandibular gum pad. So whenever a child is born, initially you see the upper jaw forward and the lower jaw far behind, retrognathic. The reason, cephalocaudal gradient of growth, because the lower jaw has got lot of time to develop postnatally when compared to the maxilla. Both maxilla and mandible will develop, but mandible will develop farther away from the maxilla. And then your anterior open bite. Now anterior open bite is essential to have a infantile swallow for suckling reflex. So that anterior open bite is must. So these are all self-correcting anomalies in predentate period where you don't have teeth. Next comes your dentate in that primary mixed permanent. Okay. So, a 9-year-old child comes to a dental office with spacing in the anterior teeth. What is the line of treatment? This is nothing but your ugly duckling. Whenever you say 8.5, 9, 9.5, 10, till then ugly duckling. So, hardly any treatment is required, no treatment. Okay. So, no treatment and observation. So, whenever you tell a patient that he or she does not require any treatment, you have to be cautious in explaining the patient and the parents why. So, you should have that scientific knowledge why this condition is. So, you have to tell them because of the canine. This is the problem. So, you come to me every 3 months or 6 months, you monitor it and you show them. Okay. Then supervision of child's dentition is critical at what stage? Child's dentition means the pattern of sequence of eruption. Now, that is critical in the mixed dentition, isn't it? The transition of dentition from primary to permanent will occur during the mixed dentition between the ages 7 to 11, isn't it? Because by 6 years your first permanent molars erupt, and 6.5, 7 you see your incisors developing. Till the age of 11 your premolars will erupt. So, 7 to 11, so the closer choice is 7 to 10 mixed dentition. Okay. After that there is nothing to monitor much, most of the teeth have erupted, only your second permanent molar will erupt, that is all. And here only there is every possibility that the teeth might erupt in a erratic pattern if there is any problem. Okay. So, supervision of the child's dentition is more critical during the transition of mixed dentition from 6 to 12 years. Now, change in the arch length from the mesial surface of the first permanent molar between age 6 to 10 is decreased by how much? See, normally the arch length, now arch length means it is measured, it is basically a misnomer. Now, here if you see, this is called as arch length. Actually, this is called as arch perimeter or arch circumference, and this is your incisor, this is your intercanine, and this is your intermolar. Okay. But many a time in exam, if you say arch length, it is nothing but your arch perimeter only. Actually speaking, arch length is that from the midline down. Okay. But arch perimeter or arch circumference only is referred to as arch length. Now, what happens with age? The arch length decreases, it does not increase. The arch length will not increase. You might be thinking many teeth, so the arch length will increase. In primary dentition only 10 teeth in the one arch, but in permanent dentition there are 14 teeth, so arch length. But arch length you measure from the mesial aspect of the first permanent molar. Okay, so that is the reason the arch length decreases. Why it decreases we all know. Your leeway space, forward mesial shift, either early late, clear. There is little ambiguity here, it is 0 to 1 and 3 to 4, but when you see in the upper arch it is less, lower arch it is more. It is clear, because upper arch it is only 1.8 millimeters, lower arch it is 3.4. So, to be precise, we have placed it as decreased by 0 to 1 millimeters, because he has not mentioned the arch. Okay. That has to bound to happen, whereas in maxilla it will not decrease by 3 to 4. You understood? So, this you have to be specific. If he asks arch, then upper means that, lower means again this. Okay. Now, here see that the arch length decreases by 1 mm due to the uprighting of the incisors, the lower, and arch perimeter decreases by 2 millimeters in the upper, 4 millimeters in the lower. You understood? Because this arch perimeter, see the first line, perimeter sometimes 1/2 of the circumference is referred to as arch length. So, this is the confusion. Now, arch length would have been, ideally speaking, this is the arch length. Okay. That also decreases, because your incisors which are proclined will upright. But when you see your arch perimeter from here to here, that is arch perimeter, this entire thing, that also decreases. So, the arch length or arch perimeter both decreases. arch perimeter or arch circumference decreases more when compared to arch length. So these two words are slightly misused, like I said biomaxillary protrusion, they are misinterpreted and misused. But many a times arch length means nothing but your arch circumference only, many a times. If they specifically give that, then it is a problem. Both decreases, that is one plus point. So the magnitude is upper little less, lower more. In the absence of permanent second premolar, the roots of primary second molar will most likely, what will happen? There is no succedaneous teeth. So in the absence of a succedaneous tooth, the resorption will be at a lesser pace, or it might not resorb also. It might be over retained, isn't it? So resorb slowly than normal pace. Eruption of permanent maxillary second molar before maxillary second premolar. So your permanent second molar, that is 7, is erupting before 5. 7 is erupting before 5. Is it desirable and is it usual? It is unusual and undesirable, isn't it? The usual pattern of eruption is 5 erupts before 7, isn't it? So if 7 erupts before 5, it is unusual and also undesirable. Why? What happens? The space of 5, there will be some amount of mesial migration. So 6 will drift into 5 and 7 will further exert force on 6. So the space for 5 is lost and obviously the tooth will be malposed, okay, out of arch. So eruption of second molar prior to second premolars lead to decrease in the arch length, isn't it? So thereby results in crowding of the buccal segment. The tendency for drifting of posterior teeth into extraction space is more in, like if one tooth is lost, so drifting will occur, mesial migration will occur. We all know there is a phenomena called physiological mesial migration of the teeth because of the inclinations, and the angulation of the eruption of the teeth, there is some amount of physiological mesial migration. So whenever a tooth is lost, the drift will be into the extraction space. So he is saying it is more in case of which? Maxilla, mandible, both are this. It is more in case of maxilla because of their inclinations and relatively a less compact bone in maxilla, whereas mandible it is a compact solid bone when compared to maxilla. Maxilla is a dense, whereas it is a dense bone in case of a mandible, whereas it is a cancellous bone in case of a maxilla. So the tendency for drift is more pronounced in the upper posterior region when compared to the lower. So premature loss of upper primary first molar leads to, so when there is a premature loss of a primary molar, as I said earlier, the tooth distal to that will migrate mesially, so it will leads to loss of arch length, so which will again lead to crowding. Do you see crowding in the incisors because of a molar loss? You will not see. Do you see spacing? No. Will arch length increase? No, it will decrease. You will see crowding in relation to the buccal segment, that is a premolar segment, not the incisors, okay. So in case of a premature loss, the first permanent molar migrates mesially, so you see loss of space for your second premolar. The erupting second premolar is deflected and erupt in an abnormal location, so leading to a malposition and a malocclusion, okay. And the arch perimeter or arch length or arch circumference is decreased. The slower phase of eruption once the tooth reaches the occlusion is termed as, what is this? Is it post-emergent phase, pre-emergent? Pre-emergent is before the tooth erupts. That is, as I said, the eruptive tooth movements will start in stage 6 once the crown is completed. Whereas this post-emergent phase will start once the crown breaches the oral cavity and enters the oral cavity. That is when 2/3 of the root is formed in the 8th stage. So now this is called as, this is slower, this is a passive phase where the teeth has to reach the occlusal level. So that is called as juvenile occlusal equilibration. there are two things, juvenile and adult occlusal equilibration. That is passive eruption, what you see in adults. See, one tooth is missing, okay. So the opponent tooth will slightly supra erupt, even in adults. That is the reason why we say we have to replace teeth, isn't it? So that is in adult. So that is adult occlusal equilibration. So that is some amount of eruptive force is there in the tooth, even in an adult, because the opposing tooth is not there. So eruption has not ended once the tooth is erupting into the oral cavity. So that is juvenile occlusal equilibration. Now why an implant or crown has not to place is this. Till the juvenile occlusal equilibration occurs, you should not place a PFM crown nor an implant, because they will restrict the juvenile occlusal equilibration of the adjacent teeth. They have to erupt. There will be a contact. Now contact will stop. You understand? You have to have tight contacts. If there are no tight contacts between your pontic and the abutment, then what will happen? They will lead to foot impaction, then periodontitis, isn't it? So that is it. So juvenile equilibration is the phase where slow phase of eruption occurs once the tooth reaches occlusion. So what is post-emergent phase? Once the tooth emerges into the oral cavity till it reaches the occlusal level, it is post-emergent phase. Okay. The stage of relatively rapid eruption from the time the tooth penetrates the gingiva and reaches occlusal level is post-emergent, and in contrast a very slow eruption occurs in juvenile occlusal equilibration. It is very less, hardly you can see anything. What is the result of the muscle forces acting through the intercuspation of occlusion? Even when the teeth are intercuspated or when all the teeth are aligned properly, still they have some mesial component of force. What is that force? That is called anterior component of force. Don't confuse with mesial drift tendency. See, mesial drift is a physiological mesial migration which is inbuilt in the tooth because of the inclination of the teeth, because they erupt mesio-occlusally, teeth erupts. So that is a mesial drifting, that is a physiological mesial drifting. But the result of the muscle forces acting through the intercuspation of the occlusion generates anterior component of force. Okay. The dentition is basically held in neutral position by number of forces, that is forces acting from outside and forces within. Now forces within is your tongue and forces outside is your buccinator mechanism, isn't it? That is nothing but your extraoral muscles. I will explain that later. So a neutral zone exists where the dentition is placed subject to the forces intraorally from the tongue and extraorally from the other muscles. Okay. So the teeth which are in occlusion have a tendency to drift mesially, and this is called mesial drifting phenomena, whereas when the teeth occlude with the opposite arch, they have got with their inclination some amount of forces which are generated, and these forces which are generated based on the axial inclination of the tooth between the contacts of the teeth, this is referred to as anterior component of force. So this is a horizontal or an anterior component of force in addition to the vertical forces, and the axial inclination of these teeth is what which causes the force to generate. So this is referred to as anterior component of force, and this is often confused with the mesial drifting tendency. So this is the result of the muscle forces which acts through the intercuspation of the occlusal surfaces. Okay. So you have to intercuspate, you have to bite, you have to use your muscles of mastication. Your muscles of mastication are what are coming into picture whenever you have to bite. So that muscles will cause through the contacts. So all contacts progressively from the second molar to the incisor, you have got an anterior component of force. Okay. Whereas the mesial drifting is because of the teeth which drift mesially normally in occlusion. So the anterior component of force is effectively countered by the contacts and the musculature of lips and cheek. Why the teeth are not coming forward? If there is some component of force, with age the teeth have to come forward, isn't it? But still they are not. Reason being, the lips and the cheek will try to hold them, isn't it? And in addition to that, you have a periodontium. Periodontium will hold the teeth, they will stabilize. So, why after the age of 45 or 50 you see the teeth drifting? Many people will complain after the age of 35 or 40, they say my teeth have come front, or my teeth have drifted down, or spacing was not there earlier, all my teeth are aligned properly, now suddenly there is spacing. Now all this is because of the periodontal breakdown and lips and everything becoming flaccid, tonicity lost with time, and your anterior component everything expressing, and mesial migration, isn't it? Then the spacing comes. Otherwise the teeth are actively stabilized by the periodontium and the interaction of your buccinator mechanism with the tongue. The tongue pressure is sufficient to move your teeth, because as I said earlier, thumb sucking, tongue thrusting, these are enough to move your teeth. The extraoral musculature is not enough. The tongue is a muscular organ. The moment it pushes, it applies force, they will move forward. Okay. When permanent canines are lost prematurely, the permanent incisors may drift. When permanent canines are lost prematurely, the permanent incisors might drift distal. We are all the while telling mesial, mesial, mesial. Okay. But whenever we see an extraction space, there is a tendency for the distal tooth to move mesial and the mesial tooth to move distal. But any point of time, the tooth which is distal will move more mesially than the tooth which is mesial. See, canine is lost, so the incisors are ahead, so they have to move only distally into that space, they cannot move mesial. Whereas the premolar can move mesial. Premolar movement only will be more when compared to the incisor, but incisors have to move distally. So you should not confuse here and put mesial. Okay. There is no way it can move, it will move mesial, but since extraction space is there, obviously since the lack of contact, there is more tendency for it to move distal. This condition is seen rarely, give rise to the distal tipping of incisors and possible mesial movement of premolars. And what happens there most is the result in lingual tipping of these erupted incisors. The most accepted cause of late incisor crowding, we see after the age of 17 or 18, suddenly there will be some amount of lower incisor crowding especially. What is the reason? It is because of the late mandibular growth. It is because of late mandibular growth. See, pressure from third molar, lack of normal attrition, these all contribute. I am not saying most accepted cause, that is what you have to see. These all three are the causes, A, B, C, all are causes only. But most accepted among them is late mandibular. Okay, if you see the literature, all these three are the causes, A, B, C are all causes for late incisor crowding. No treatment. Treatment in the sense, see, you can't control late mandibular growth, isn't it? That is the reason whenever we debond any case after 14 or 15 or any early age, see, whenever we do fixed orthodontics, we wait till the eruption of all the 14 teeth to erupt, that is your second molar. So probably we start at the age of 12 to 13, we start. By the time we complete, it will be 14 to 15, okay, 2 years, 1.5 to 2 years. So what we do, we give a permanent retainer. The purpose of giving permanent retainer from canine to canine is to prevent this, and we say the patient, ideally patient has to be followed up every 6 or 9 months to monitor this, because we can't do anything for it. You can't, this is natural growth, nothing is in our hands, we can't prevent the late mandibular. See, if you third molar, yes, you can see the angulation, by then only you will know, you will caution the patient, it is mesioangular, it is not vertical. Then you can tell the patient to come after 6 months or 8 months or 10 months or later, and you can remove third molar. So you can nullify that factor. And attrition, nowadays there is no attrition only, so no problem because of the soft diet. So this factor you can't. So you give a fixed retainer. That is the only preventive thing you do to prevent the late lower incisor crowding. And it is not that it happens in all the cases, and the extent varies. So the three major theories are lack of attrition, because of the modern diet, which is soft diet. Earlier there was coarse diet. So there used to be occlusal and interproximal attrition too. Occlusal and interproximal attrition, and the contacts were broad, not point contacts. Interproximal contacts were broad because of the coarse diet. So the teeth used to accommodate. Now how this contributed? There used to be some spacing, and the lower incisor crowding, what I have told, we used to spread out because of the space gained from the interproximal attrition. But now because of our soft diet, there is no occlusal attrition nor interproximal attrition. Okay, one thing. This is ruled out. Next is late mandibular growth because of the rotation of the jaws, and this is most accepted. And these three events can occur simultaneously, and one is more important among them. And pressure from third molars, and late lower incisor crowding or lower incisor crowding is referred to with one term called as imbrication. Lower incisor crowding or displaced lower anterior contacts or irregular lower teeth referred to as imbrication. So it seems logical that because of your mandibular rotation or late mandibular growth or differential mandibular growth, there is late lower incisor crowding. Prolonged retention of primary teeth may result in, what it will result? Obviously, it will result in ectopic eruption of the corresponding or succedaneous teeth. Okay. Ankylosis of permanent teeth? Not at all. Ankylosis is lost, there should be no periodontal ligament, isn't it? The moment there is periodontal ligament, the tooth will erupt. Why will the tooth ankylose? And then resorption of the roots of the adjacent tooth. Why will it resorb adjacent teeth roots? It will not. So the option is there will be ectopic eruption of the permanent teeth. So prolonged retention of the deciduous teeth can cause impaction of the permanent tooth and deflection in its path of eruption. Okay. Name the muscle group which opposes the buccinator mechanism. As I told earlier, it is tongue. What is acting from inside? It is the tongue. And the bands of musculature, what is buccinator mechanism? It is nothing but this entire band. Okay. So running from the orbicularis oris, the buccinator, and then to the superior constrictor of the pharynx to the pharyngeal tubercle. So the encirculating band around the oral cavity is nothing but your buccinator mechanism. So there exists a balance between the buccinator mechanism and the tongue. So all these three muscles exert inward force on the dentition. To counteract, you have got a tongue which neutralizes, and the stability and the position of the teeth in the arch and the dentalveolar complex is by your neutral zone, or the phenomena of neutral zone is because of your tongue and your buccinator mechanism. Grooves which are present in the gum pads between the canine and the first molars and relates to the upper and lower gum pads. So as I said, there are transverse grooves between the deciduous segments. There are 5 or 10 which will divide into 10 compartments. So now there is one groove which is prominent between canine and the first primary molar, that is referred to as lateral sulcus or lateral sulci. So the upper and lateral sulcus will give us the anterior-posterior relationship of the upper and lower arch. So the transverse groove between the canine and the first deciduous molar is called lateral sulcus, and it is essential for judging the interarch relationship at an early age. That is the sagittal position. This is the lateral sulcus, this is the upper gum pad, lower gum pad. So the lateral sulcus of the mandibular arch is more distal, isn't it? So it is, otherwise it exhibits a class 2 or a post-normal relationship, or you have got a retrognathic mandible. And when the gum pads occlude upper and lower, you see a complete overjet all around, and there is an anterior open bite, isn't it? You see a complete overjet and an anterior open bite. Now this anterior open bite in the predentate period helps in suckling reflex and infantile swallow, which is absolutely normal, no treatment has to be done. So basically this is a transient open bite and infantile open bite which helps in suckling, and all this closes by the eruption of the primary teeth. At birth, gum pads are long enough to accommodate all the primary teeth. At birth, during the birth, all the primary teeth. Only primary teeth will erupt by the age of 3 years. All the teeth. By 30 months, most of the primary teeth would have erupted, 24 to 30 months. So the gum pad is sufficient enough to accommodate only primary teeth. Don't write permanent tooth or first molars. So only the primary teeth. Because first molars erupt at 6 years. Dental age, again same thing. Refers to state of dental maturation, yes. Correlated to skeletal age, yes. Independent, yes, we can correlate, and at the same time it is totally not dependent on skeletal age. So all of them, as I told you earlier, neither chronological age nor skeletal age nor dental age are independent of each other. They can be correlated and they are independent of each other. Identify the correct statement about deciduous teeth. Maxillary teeth calcify first, but mandibular teeth erupt first. Among the deciduous teeth, which teeth erupt first, upper or lower? Lower teeth. So this part of the statement is correct. Mandibular teeth erupt first, isn't it? But if you see the calcification part, maxillary teeth calcify first, not the mandibular teeth. This is the contrast. Lower teeth, lower primary teeth erupt first, but calcification occurs first in the upper teeth. Okay. So most of the upper primary teeth calcify first, except for primary first molars, whereas mandibular teeth erupt first compared to the maxillary, except for lateral incisors. You see lower central incisors primary, then upper central incisors, then you see upper lateral, then lower lateral. Most of the times, it is not that it is mandatory that it has to be followed. Okay. And pattern is A, B, D, C, E. So enamel formation of primary teeth of all the teeth is completed by, enamel formation is completed by 1 to 11 months of all the primary teeth. So most of the primary teeth. It is initiation starts itself in the first trimester of pregnancy for the primary teeth, the crown formation, and initial calcification you see in the and initiation of permanent teeth 4th month. In the first trimester you see initiation of primary teeth. 4th month you see initiation of permanent teeth and calcification of primary teeth. Okay. And then crown formation is completed by 1.5 months of age, and by 10 to 11 months most of the formation of crowns of even primary second molars. So your answer would be by 1 to 11 months. So you see the crown formation in the first trimester, primary teeth, and the second primary molar crown formation is almost complete by 12 months. Okay. And the root formation of primary teeth is completed by 1.5 to 2 years, and eruption is completed by, whereas in permanent teeth it is 2.5 to 3 years. After the tooth erupts into the oral cavity, then the root formation totally is completed by 2 to 3 years in permanent tooth. Okay. Teeth that are initiated after birth. After birth, which are the teeth that are initiated? As we all know, before birth, at the time of birth, primary dentition and the first permanent molars. So now what are left with? Premolars, permanent second and third molars is one choice which is correct. Premolars and permanent molars not correct, because first permanent molars are already formed at birth. Then all permanent teeth not at all, only permanent molars not at all. So left choice is premolars and permanent second and third. So premolars are initiated at 8 to 10 months, permanent second molars 2 to 3 years, third years at 5. Okay. It is only initiation, not calcification. Calcification you see at 6 to 8 years in third molars. So accepted latency between exfoliation of deciduous dentition and eruption of succedaneous permanent teeth. That is, latency is like how much time you can wait till a permanent tooth, succedaneous tooth erupts. Now a tooth is exfoliated. For how long you can wait? Patient is in a hurry. Whether you want to know whether the tooth is there or not. So how much time you can tell him to be happy? At least 3 to 6 months. 3 to 6 months, there is no harm in waiting. After 6 months, definitely it is a thing which has to be intervened. You have to take an X-ray and check whether there is a permanent tooth, succedaneous tooth there or not. So 6 months is what is the time you can minimally give between the exfoliation of a primary tooth to the eruption of the succedaneous teeth. Okay. Or you can counter check the opposite side. If the contralateral side the tooth is erupted, then this side also you can check. That is also an ideal clinical checkpoint. In an exam point of view, it is 6 months is what is the time you can wait. Calcification of first permanent molar starts at birth. First evidence of calcification of second premolar on radiograph is at, as I told just now, between 2 years. So it is 1.5 to 2.5 years. Premolars. So second premolar, usually most variation in the calcification, it is around 2 to 2.5 years. But sometimes it may show initial calcification after 4 years also. That is the reason one question I have asked you, 4 years a child is presented with an X-ray and you have not seen whether the second premolar is formed or not. But still we said the tooth doesn't form, is we said we can wait. We cannot comment. It might develop later because it is more anomalous, second premolar. Okay? But after 4 years definitely it is not. Till 4 years is what you can wait. Even after 4 years it doesn't form, then absolutely the tooth will not form. First evidence of calcification of third molars. First evidence of calcification is, now 6 years you cannot give, so calcification, this is initiation. So calcification is 8 to 10 years. So 10 years is a probable answer. Average variation in eruption of permanent molar is considered 18 to 24 months, that is 1 to 2 years. So the time between exfoliation of deciduous and the permanent succedaneous eruption is 18 months. See, approximately a tooth erupts and the permanent tooth to erupt, it will take 18 months the difference. The variation, many cases it will erupt within 6 months, but there are cases where the tooth would have erupted late by 12 to 18 months also. This is the maximum time. So average variation in the eruption of permanent tooth here is 12 to 18 to 24 months, that is approximately 2 years. First molar, it can start as early as 5.7 years only, not 6 years. See, 6 years is an average, average is 6.6, late is 7.5. Okay. Even till the age of 8 years also the first molar has erupted in few cases. Okay. So this is the variation from 5.7 to 7.7, how much it is? 2 years. An early eruption, it is 5.7, late eruption is 7.7. So that itself is 18 to 24 months. That could be the variation. Understood? When a permanent tooth emerges clinically, how much of the root structure is most likely to have developed? Straightforward question again. 2/3 of the tooth root has to form. Nola's 8th stage. When a tooth is erupting the oral cavity, 2/3 should have formed. Eruptive movements will start when the crown formation is completed. That is in the 6th stage. Okay. When 2/3 is formed, it will erupt. So whenever you see any retained primary teeth, the clinical checkpoint is the moment you have a radiograph with you, see whether 2/3 of the permanent tooth root is formed. Immediately remove the primary tooth. You can tell the patient confidently that 2/3 or 3/4 of the permanent root is formed, that primary tooth has to go. If it is still in the oral cavity, remove it off. And check the opposite side. Blessing in disguise, nature has given you right and left. So check the other side. Other side the tooth has erupted, then immediately remove this tooth. Okay. So 2/3 the root is formed, then the tooth is erupting clinically into the oral cavity. This is what anteriors around 60 to 70% form, premolar 60%, molars 40%, even then the tooth forms. Half to 2/3 the tooth emerges through the alveolar crest. Stepchild of dentition in permanent is third molars, stepchild. Cornerstone is canine. The maxillary canines are cornerstones. Third molar is called stepchild. In cretinism, the dental delay when compared to the skeletal delay is about, this you have to by heart, that's all, 1/3. The dental delay when compared to the skeletal delay is 1/3. What it says is the dental development is delayed when compared to the skeletal by 1/3 of it. The dental delay is not much marked as compared to the skeletal delay. Whereas in all other conditions it is usually 1/4, whereas in cretinism it is 1/3. The most documented evidence of supernumerary teeth or congenital anodontia is hereditary and familial. The most common cause for a supernumerary tooth or a mesiodens or congenital anodontia, the absence of the teeth or presence of extra teeth. The etiology is hereditary or familial. Supernumerary tooth in anterior region commonly found is, it is found palatally in the upper arch between the central incisors, that is nothing but your mesiodens. Okay? Here you can see the mesiodens. These are your two permanent central incisors. If a child has stayed for the first month of his postnatal life in the fluorinated area, first 1 month, then which portion of the first molar will show deposition of the fluoride? See, you know at birth your first permanent molar is formed, isn't it? So, the enamel, basically there is enamel and dentin at the most. So, which portion do you think will form? Which portion you will see there is fluoride? See, is it the outer layer or deep layer? That is what is the confusion. Definitely it is not the outer layer, because the enamel will deposit gradually. So, the initial enamel would have gone deep, isn't it? And whereas in dentin, is it again the outer layer or inner layer? It is opposite here. In dentin it is the outer layer, not the deep layer. Why? Because it approaches towards the pulp. Dentin comes from the pulp. See, newly formed enamel will move outwards. Means the newly forming will be on the outer aspect and the older enamel will go inwards. That is deeper. Whereas dentin will move towards the pulp, forming the DEJ. That is the reason it will be the answer would be the outer layer of dentin and the deeper layer of your enamel, not the outer layer of enamel. A 5-year-old child received tetracycline therapy. Which of the following teeth are affected? 5-year-old child. 5 year, which are the teeth which are getting calcified? Now, if you see, it would be your canines, premolars and second molars also, because the calcification starts by then, isn't it? Definitely incisors, canines by incisors would have been over by then. First and second, third molar no way. First molar already over by then, isn't it? So, it is canines and premolars. And see, these teeth all erupt between the age of 10 to 12, isn't it? So, the calcification starts at 5 to 6 years. Permanent mandibular incisor buds relative to primary incisors. How your permanent incisors are? They are lingual. Most of the times parents come at the age of 7 or 8 years telling that their child is having the teeth which are coming inside, isn't it? They are coming crooked and inside. Absolutely normal. Why? Because the succedaneous dental lamina is lingual or palatal, isn't it? So, obviously any permanent tooth or succedaneous tooth will erupt lingual or palatal only. Once the primary tooth falls off or exfoliates, with the force of tongue is enough to push the teeth into a normal arch position. So, the primary permanent incisor buds are basically lingual and inferior. Most frequent cause of fracture of a root tip during extraction of a primary molar is the root resorption between the apex and the bifurcation of the primary molar. What he is asking is, what is the frequent cause of the fracture of the root tip during extraction, not your ankylosis or forceps, because there is asymmetric root resorption. There is an asymmetric root resorption where one root has resorbed more when compared to the other root. That is why you see the fracture of the root tip. Okay. In any primary molar extraction, if there is a fracture, you have to suspect asymmetric root resorption. Both the roots would not have resorbed properly. Spacing of primary dentition is absolutely normal and is desirable for accommodation of large permanent teeth. That is physiological spacing. Upper it is almost 4 and lower it is 3 millimeters. Which among the following is the most common finding of the deciduous dentition? That is your tight contacts and absence of spacing. Not here, this is a negative question, not a common, this tight contacts and absence of spacing. With respect to their permanent successors, the sum of the mesiodistal diameters of first and second deciduous molars is generally greater. The first and second deciduous molars, the mesiodistal width is more, isn't it? Primary molars. That is your leeway space. So when you minus CDE from 345, it is 1.8 in the upper and 3.4 in the lower. Child has a flush terminal plane early in mixed dentition. Movement of the lower molar forward relative to the upper molar to achieve class 1 is by approximately the lower molar has to move forward by around 3.4 millimeters. The leeway space is 3.4, isn't it? So one cusp is approximately around 4 millimeters. So that is 3.5 millimeters. Lower molar is moving forward. Leeway space helps in the development of normal occlusion by providing or allowing the mesial drift of the molars. How leeway space helps in late mesial shift? It allows the molars to drift mesially. It will not erupt premolars. Already premolars are erupting. It is not courtesy the leeway space. The primary tooth is there. Instead, in the place of primary tooth, your premolars are erupting. Because the premolars are less in the mesiodistal width, that space is utilized in leeway space. Leeway space was given by Nance and it accounts for the late mesial shift. This is primate spaces which account for your early mesial shift. Greatest amount of intercanine width occurs in the maxilla at the time of eruption of the permanent. Intercanine means canines. Maxilla intercanine width increases approximately 5 millimeters. Mandible around 4. Normally mandible is completed by 9 to 10. Maxilla, the other question we were dealing, 10 to 12 years in females and up to 18 years in males. 15 to 18 years. Intercanine width in maxilla. Mandible 9 to 10 years. This phenomenon may extend up to 12 years in girls and 16 to 18 years in boys. Safety valve mechanism. This is one more important thing. This is basically courtesy of what? Safety valve mechanism. This is because of the maxillary intercanine width. The maxillary transverse dimension acts as a safety valve for the sagittal position of the lower jaw. I will repeat, the maxillary intercanine dimension, the establishment of the maxillary intercanine dimension acts as a safety valve for the sagittal position of the mandible. Reason, if you have a constricted arch or a narrow palatal vault and a narrow arch in the upper, the mandible is contained within. The mandible is contained within and it will not grow forward. You understood? That differential growth of mandible which has to occur will not happen. And you know cephalocaudal gradient, the mandible has to grow little later. But since the maxilla is constricted transversely, it will not allow the mandible to grow out. Okay. Now, if that does not happen, then you will end up in a class 2, skeletal class 2. So, if your maxillary intercanine width is established adequately, then there will be a sufficient forward or sagittal growth of the mandible. Okay. So, this acts as a safety valve. So, the transverse dimension is acting as a safety valve for the sagittal dimension. So, the intercanine width of the maxilla acts as a safety valve. There is a mismatch in the horizontal growth of the maxilla and mandible. The sagittal growth of the maxilla, which is situated closer to the cranium, is completed first. Maxilla grows earlier, the sagittal growth is complete, whereas mandible sagittal growth will occur later. Now, that depends upon the intercanine width of the maxilla, which will establish by the age of 10 to 12 years. In primary dentition, the anatomic structure used to determine the molar relationship is, in primary dentition, which anatomic structure is used to determine the molar relationship? The distal surface of your primary second molar, which helps your flush terminal plane. Okay. That is your flush terminal plane. Mesial step, distal step, already I have told you. So, distal step will end up in class 2 or post normal dentition, okay, or disto occlusion. A mesial step will end in class 3 or prenormal or mesio occlusion. Which of the following can be predicted from flush terminal plane or primary dentition? Always result in class 1, we do not know. Result in class 2, class 3, we can't tell. It is normal, but the final molar relation cannot be definitely predicted, because a flush terminal might end in end on, or it might end in class 1 also, because of your mesial shift. So, it is absolutely normal, but you can't predict the final molar relationship. Mesial step formation in deciduous dentition will indicate future class 1, class 2, class 3. Mesial step is class 3. Mesial step is class 3. This is your mesial step. Lower dentition is ahead. See, lower dentition is ahead. The ugly duckling stage is seen at what age? It is 8.5 to 9.5 years. So, the closest matching choice is 9 to 10. Ugly duckling stage is called so because discrepancy of tooth size and size of the face? No. Because the fan shaped central incisors? No. Fanning of central and lateral incisors? Yes. Fanning means they are distally angulated. So, C is the choice. In children, median diastema between maxillary permanent central incisor closes with the eruption of, or midline diastema in children closes with the eruption of permanent canines. Which canine? Upper canine. That is same your ugly duckling stage. Which of the following is not a transient or self-correcting malocclusion? Spaced primary dentition, it is absolutely normal, isn't it? Because you need the physiological spaces. Deep overbite in primary dentition, absolutely normal, because till your permanent molars are erupted, you will see deep overbite. Okay, flush terminal plane, normal. Later it will either mesial shift early or late. Anterior crossbite, it is not transient, it is not self-correcting. You have to intervene. Okay, anterior crossbite is not transient. Transitional phase of dentition is when eruption of permanent teeth and exfoliation of primary teeth. The first transition occurs between 6 to 9 years, where you see your first permanent molars and also you see your incisors. Okay. Then there is intertransitional phase, stable phase, 1 year approximately nothing occurs. Then later 9.5 to 10 to 12 years you see your canines and premolars. Okay. After mixed dentition stage, the arch length from first molar to first molar usually decreases. This I have told you earlier. Arch length will decrease. As I told earlier, the arch length will decrease by around 4 millimeters in the lower and 2 millimeters in the upper. The change is in a greater extent in the lower arch than the upper arch. Molar width increases, intermolar width increases. Between 5 to 12 years, the following changes occur with relation to overbite. Increase in the absolute value due to the change in dentition. Constant percentage of overlap is maintained. It might increase, decrease or remain same. With relation to overbite, anything can happen, isn't it? So, all of the above. Either it could be an increase in the absolute value due to the change.
I like to take an opportunity to introduce Dr. Karina Agarwal. Sir is our orthodontic teacher, and Madam post-lunch will be reviewing oral pathology. Madam just came from Mumbai for all of you, so we wish that we will have a wholesome class.
Yes.
So,
right.
Thank you.
So, increase in the absolute value due to the change in the dentition, constant percentage of overlap, increase, decrease or remain same, or all of them. So, most of the things can be, all of the things can be true with regards to overbite. Now, as I said, overbite will decrease with the eruption of permanent molars. Overbite will decrease with the eruption of permanent molars. So, transitional anterior open bite is seen in the mixed dentition. Early mixed dentition, you see deep bite. There is absolutely no harm. Till your second permanent molar erupts, the deep bite will not reduce. So, all these three things you can see some amount of change, there will be overlap, it might increase, decrease or remain the same. So, no comments with regards to deep bite till the age of 12. Why he has specified 12? Because 12 years is when you see the eruption of your second molars. So, this is self-correcting and anterior bite is relieved by pivotal growth spurt and once your permanent molars erupt. Clear? And premolars are also erupting into the occlusal plane. If a succedaneous tooth fails to erupt corresponding primary molar, what will happen to it? Obviously, it will remain there only. Succedaneous tooth is not there, roots will not resorb, it will just remain like that. For how many years? It can remain as good as 30 years also it can remain. Basically, this thing it will not resorb. See, we have to eliminate here. So, it will not resorb quickly. It will resorb and exfoliate as usual? Absolutely not. And submerge in later life? No. Space closure is rapid following loss of which primary molars? So, obviously, it is space closure is rapid following loss of which molars? Now, why it is maxillary molars is, the reason is, yeah. So, this will occur more in relation to maxillary and it will close within 6 months. As I said, the tendency of mesial drift is more pronounced in the upper posterior region. Premature loss of upper primary first molar leads to premature loss of upper first primary molar. So, upper first primary molar, that is D, when D is lost, it leads to a blocked canine. Why? Because the permanent, the first premolar would have erupted in this region. The moment your upper primary first molar is lost or prematurely lost, the permanent first molar will erupt. The moment it erupts, it will go into that space. So, it will block the canine and it will lead to transposition, as I told transposition. So, in the place of 3, you will have 4. The maxillary first premolar erupts uneventfully before the permanent canines and the canines are then blocked out, most probably either labial or transposed, either of it. A 5-year-old prematurely lost a mandibular second molar. Subsequent arch length loss at 6.5 years of age is due to. Now, 5-year-old lost a mandibular second molar. Now, what happens? Then there is some amount of arch length loss. Why arch length loss? This is a E which is lost. So what will happen to the 6? The 6, that is the first permanent molar, will erupt into the place of E. So you are losing your leeway space of NANCE also, isn't it? So there will be loss of your arch length. So it is because of your eruptive forces. So what is contributing to the loss of arch length here? Eruptive forces, isn't it? The 6, the first permanent molar is erupting in the place of second, in the loss, in the where the second premolar has to erupt, and at the cost of leeway space it is erupting. Okay. Yeah. Not growth. Growth in what way growth? Which is growing there? Mandible is growing normally. You understood? Mandible is growing normally. Teeth are not growing, teeth are erupting, isn't it? Yes, but that is not there here. Now, how that mesial drift occurs? It is in a occlusal pattern, mesio-occlusal pattern. But that is, first the teeth have to erupt into the oral cavity, then only the occlusal component is. Even the occlusal force also you can't say. You can say molar, eruptive force of molar. Yeah, it is in the occlusal direction. And mesial, see, always the teeth erupts mesio-occlusally, most of our teeth. The inclination also is like that. That's why you have that mesial drifting tendency. But do you have any choice of mesial drifting here? No. You have any choice of physiological mesial drift? No. Then the obvious choice is the eruptive forces. You can't tell occlusal. See, you might be confused between eruptive and occlusal at the most. You can't tell occlusal force because tooth itself is not in the oral cavity. Leave about occlusal force. It erupts only at 6 years. So, see, the angulation itself is changing in the pre-emergent stage. See, a tooth is missing. Okay, this is pre-emergent phase. This is not post-emergent phase. Now, post-emergent, definitely occlusal will come into picture. So that's why it's very specific, 6.5 years. See, this first permanent molar might erupt from 5.7 to 7.7 years. Okay, so 6.5 is it is in the pre-emergent phase. So the arch length loss in this case is due to the mesial eruption of the first permanent. The angulation itself is changed, the path of eruption itself is lost. See, the muscle forces, occlusal forces do come into action once the teeth is erupted, isn't it? The total eruption path of first permanent molar is around 2.5 centimeters. Total eruption path, how much it traverses, is around 25 millimeters. Okay. Which tooth loss makes greatest changes in the facial expression? Obviously, it is the upper canine. It is the cornerstone of the mouth. Which of the tooth have a natural tendency to drift mesially is your molars. Okay, permanent molars. Crowding that occurs after age of 18 is the result of all except after the age of 18 is the result of all. Impacted third molar, yes. Orthodontic relapse, yes. Physiological maturation changes, yes. Periodontal disease, no, not at all. At the age of 18, teeth are sound, isn't it? After 30 or 40, you can sell periodontal disease. See, definitely an impacted third molar might cause crowding, as I told you earlier. Then orthodontic relapse is definitely a cause, or physiological maturation changes, that is your differential growth. Differential growth. Okay. Early loss of permanent molar at age of 9 years results in distal movement of second premolars, mesial movement of second molars. Both can occur. This is the space of 6. In the space of 6, 5 can migrate distally, 7 can migrate mesial. Yes or no? Dental arch form is finally determined by a balance between intraoral and extraoral forces, that is muzzle and tongue and buccinator. Partly by facial type also, growth pattern also, but most important is the neutral zone. Okay, these two also, but finally it is the interface of tongue and buccinator. I think we are done. Yes.